All right. You guys all know me, Heather. We're really excited about this next speaker as it's something that we all worry about in our children and spouses. She is a children's clinical psychologist in chronic illness. We'd like to welcome Dr. Laura Bennett-Murphy. She's going to come talk to us about psychological well-being in children with heterotaxy, and she happens to work at Primary Children's Hospital here in Salt Lake City. And thank you for coming.
I'm super excited to be here. So thank you. Let me just find my buttons. Hold on. Okay. So I work here at Primaries. I'm on faculty at the University of Utah, but we're also affiliated with Intermountain, so I thank them for all their support. I think what was startling to me as I really began looking at the literature is there's no literature, right? And I've been doing this working with children and families with chronic illness for a long time. And this really took me back to like the early days, right? Because I really can almost not name another syndrome or a group of conditions where there's almost no literature in terms of psychological development. And so part of that obviously is because the condition is rare, but that's not all of it, because there's certainly a number of other rare conditions and that families and children with whom I work where there is some literature. Some of it's because there's so much heterogeneity in our kids, right? So in terms of what organ systems are involved, how many surgeries, again, the severity, the pervasiveness of the body parts that are involved. And unfortunately, medicine tends to specialize by body part, as you all know. It's also really striking to me because I think in lots of other illnesses where we see these complex conditions that involve cardiology and pulmonology and immunology and rheumatology and GI, and we need physical therapy, like often we have interdisciplinary clinics to really try to consolidate care for the child and for the family so that you're not going appointment to appointment to appointment to appointment. But like I think about Prader-Willi Clinic is one I work in, and there are 10 of us that come together every other month, and so families come to us, and they just go kind of office to office, and we round. So I think because in this, for whatever reason, the way this illness has kind of evolved medically is that families are still going to these different systems, and that's an incredible burden on children and families, as you know, but it also gets in the way of our doing good research. Because unfortunately, we, like you, are busy people and sometimes are less eager to take on research studies where we have a really diverse population. So it's unfortunate. So today I'm going to be drawing on more the broad literature of children who live with chronic illness. And some of it fits better than others depending on kind of how your particular child and family have been affected. The other kind of piece, I think, is if I look back, like I was reading a study this week from last year looking at longevity and survival rates. And now, at least in this one treatment center, right, they were talking about survival rates into age 40, and again, depending on the kind of cardiac involvement, anywhere from 67 to 80%. So with our advances in medical practice, with our advances in technology, et cetera, we're now talking really about parenting into adulthood is our expectation, and that then changes the landscape. I think then people start thinking about psychological well-being and emotional well-being and developmental trajectories and things like that. So medical advances, our literature is always about 20 years behind them in psychology. So we're still catching up. Now, why even talk about psychological health? Well, there are several reasons, right? The relationship between physical health and psychological health is dynamic and bidirectional. So we all know this. When your kiddos are not feeling well, they're more irritable, they're more tearful, they're more anxious. But when you get emotional and psychological distress going up, we also see effects on, again, pulmonary systems, cardiac systems, GI systems, right? That there's a bodily breakdown that comes from chronic psychological distress and stress. So both for child's just psychological well-being and our well-being, and for their bodies, we need to be attending to both all the time. And I'll present to you the model that we use at Primary Children's. again, psychological health is often ignored, particularly early on, because I think we're just in crisis mode, right? We're literally trying to help our child survive, ourselves survive and stay intact, our family hold on. And so it often seems like the ketchup on the side, like the thing you don't need, right? What I'm going to argue is we really need to be, from the beginning, even in those moments of crisis, perhaps most of all in those moments of crisis, attending to psychological well-being, because our treatments are incomplete and they're ineffective if we don't treat the whole person. Now, the last thing I'll say is our kiddos get older. So I work in medical subspecialty clinics. I work in an outpatient clinic where we treat kids with chronic illness, and then I do 1 week a month in the hospital on call, just responding to whatever kinds of psychological needs come up. And I just got off call actually, so I apologize if I'm a little tired. But it was really interesting to me because, I was consulted this week on a young adolescent, 13-ish, who was asking for withdrawal of care. 13, and she was saying, and she actually she's not at the end of her life. And she was saying, I want to withdraw care. And my first thought was, where have we been for the last 13 years? That this kiddo's been holding on and holding on and holding on and holding on. And at 13, she hit a wall, because 13's hard when you're healthy, let alone when you've had a really rigorous life journey thus far. And now she's 13, and she's like, I'm done. I don't want to take the medicines. I don't want to do the treatments. I don't want to do the therapies. And this isn't our time to be most effective, right? I would really like to get involved in children's lives from the beginning so they don't hit that wall, because that's a really hard place for everyone in the family to be. Unfortunately, one of the things that, when I was talking to her and her mom and her dad, is she said to me, she's like, everything else in my body is broken. I didn't want this to be broken too. Or everything, and then she said, everything else doesn't work. I just didn't want to be crazy on top of it, was another phrase she used on a different day when I saw her. So that's where the stigmatization comes in, right? And, of course, in my head, I'm thinking, sweetheart, there's nothing in your spirit or psyche that's broken. You're tired. You have been pushed past your resources, but we haven't been replenishing them along the way, and the gas tank just ran out. So I guess I would argue, and I think families feel that way too, so sometimes a physician will say, have you thought about behavioral health? And again, I think the first thought on most parents' mind is, I can't go to one more appointment, right? Are you kidding me? I can't go to one more appointment. We'll find a way. Or they think, sometimes I'll hear kids say, the doctor's saying this is all in my head. So when the doctor says, why don't you see behavioral health, what the child sometimes hears is your pain isn't real, or those palpitations you're feeling are in your head, right? And so that stigma that somehow we're less necessary, we're less real, it means you're broken, it means you're crazy, I think often gets in the way in ways that this is just one more piece of the puzzle, right? You wouldn't not feed your kid. And so this is, again, I just think of it as a way of filling the tank so that car can keep running. So in our clinic, what we will say is everyone's lived experience of anything is different, right? You've probably had these conversations with your partner where you're at an event with your spouse or partner and you go home and it's like the two of you were at different events, right? You're like, wasn't that fabulous? And they were like, oh my God, I couldn't wait to get out of there. It was terrible, da-da-da. And you're like, were we at the same place? Or you might have this with your children as well. There's no such thing as real objective reality, right? It's how we experience it. And we see this in the hospital all the time, that two kids with comparable illness have very different experiences of being in the hospital. Same with adults. And again, it's one of the things that's a challenge in marriages, is your experience of this parenting journey of a child with an illness may be very different from your partner's. So how we experience something, I think the book I always go back to is Viktor Frankl's Man's Search for Meaning, right? When he described life in the concentration camp, you had prisoners who became capos, who essentially worked for prisoners who worked for their captors. You had those who gave up and died in grief, and you had those that somehow survived and held on to meaning, and then all the other outcomes in between. So how do we experience this illness in our family? Well, part of it is biological. There's no question. What systems are affected? How severely ill is this child? Are we, again, in the middle of an infectious process or right after a surgery? Absolutely, there's biology involved. But that's only a piece of the puzzle, and what we say over and over on our team is if we only treat that, we're treating 20% of the experience. For the child living with the illness and the biological piece, there's functional outcomes. Can I go to school? Can I go to dance? Can I go in the swimming pool? Right? That biological piece has a big impact on how we function and move in the world. How does it affect our social environment? And again, there are countless ways that an illness, and it's different for every kid and every family. And so does it affect friendships? Does it affect, some parents are kind of overprotective, treating that child as if they're made of fine crystal and they're going to break at any minute. Other parents are like, I'm afraid to love you because I can't do this emotional ride, and they step back. Like, how is this illness affecting that child's ability to connect with others and others' ability to connect with them, right? Again, it's hard for for healthy kids to understand chronic illness. So what are we doing in the schools and in our churches and in our communities to help the community come closer to our family, right? Or are we the one who's always having to go out? And those are probably both true. Certainly, again, as I've already mentioned, biological experiences. That's why we have terms like hangry, right? Affect our emotions. We are not a mind and a body. We're all like connected. And by the way, I'm going to talk today about kind of the particular psychological outcomes that we often see in kids with chronic illness. But understanding, this is like, so I'm going to apologize to my clinical psychologist friend for this oversimplified explanation. But in our brains, the emotion centered and the pain centers, for example, are very, very tightly wired. And it makes sense from an evolutionary perspective. If I stick my hand in a fire as a 2-year-old toddler and it hurts, it causes pain, but it also scares me, and that fear gets activated really readily the next time I see a fire, I'm not going to stick my hand back in it, right? People who don't experience fear actually get hurt a lot more and die younger. So pain and emotions are really, really wired to help us survive. And that's fantastic in that example. If I feel afraid, I'm going to stay safer. Pain activates fear, right? It's just part of it. However, if I have a condition where I experience chronic pain from repeated procedures or repeated surgeries or from the nature of the medical condition itself, my emotion systems are just getting kind of activated more often. And so, and then once the emotion system's activated, it kind of brings back to life those links of pain. I see the fire and I have this memory of pain and I have fear, even though my hand right now is safe, right? So again, it's not that our children are broken when they're anxious, it's that their brains are working, right? It's just not serving them well in the minute. And so I think helping us understand that and helping our kids understand that this isn't a weakness to be afraid. It's actually your body and your mind being smart and fighting to keep you healthy, but it gets in the way sometimes, right? It gets in the way. And then finally, as cognitive, how do we think about this? How do we understand? And how do we help our children? We certainly know that certain cognitive styles are more related to depression and sadness, and certain cognitive styles are more related to resilience. What are we thinking? How are we modeling our own thinking? What are we teaching our children? What are we hearing in their thoughts so that we can promote resilience, right? I wish every parent, every one of us wants to protect our child from difficulty, from pain, from suffering, from challenge. And when you've watched your child go through so much already, I think that drive is 10 times stronger. And I think it's the most humbling, challenging part of parenting to admit I can't protect them from some of what they're going to go through, but I can prepare them. And I can be with them, and I can partner with them. And so it requires us being very mindful of our own kind of cognitive styles in our child's as well. Now, this is just one of my patient's drawings. When I asked her to describe how she was feeling that day, because she just said, terrible, terrible, everything hurts. And I love this because, one, it reminds me A child's not dealing with, like when I'm hangry, I'm hangry, but it's all here and in my emotions, right? This kiddo, has horrible pressure and burning in her head. I have to come over because I don't have my glasses on, and I don't have my old lady glasses to see that one. Her skin, she actually has a lot of neuropathic pain. So her face just felt like it was stinging. She was exhausted. She felt unsteady, lightheaded. Her joints felt like she had broken bones. She felt like she was walking on Legos, which I think is like, again, such a great image of neuropathic pain. I'm walking on Legos. But she also said, I'm achy, it's excruciating, it's horrible, it's lonely, it's stinging, it's constant, it's stabbing, it's frustrating. That tie between the physical experience, right? We've got frustrating and lonely and exhausted, which I would say are as much emotional experiences as they are physical experiences. And in her mind, when she was describing her physical status, she was at the same time describing her emotional status. And so that's just, I think, a beautiful illustration, more than I can ever do it, of those are linked. They're always linked. So again, because we don't have a great literature for heterotaxy in general, I'm going to kind of go back. This will help you with your typically developing children who are maybe healthy and your child who has heterotaxy and everyone in between in your life. Why do emotions matter? Because again, I want to get away from this sense that they're the mayonnaise or the ketchup of life, okay? So this is just in a general developing, and this is, by the way, I don't want to get preachy, but I work with parents as much as I work with kids, and I'm a mama as well. It matters for you. And I think lots of times as parents, we're like, I'm just going to put myself over here, and I just have to help my child. Well, again, you're kind of a unit, right? Your marriage doesn't feel as great when your partner's really crabby. You're like, remind me again when we got married, right? And so it's the same with our kids. Like, I came home the other day, I thought I was doing great, I'm making dinner, and my teenage daughter goes, rough day, Mom? And I'm like, what? Like, but I'm leaking it all over, and her anxiety's coming up, right? All right, so here's just kind of Psych 101. Why do emotions matter? They're related to better physical health. In you, in your healthy child, in your child with illness, emotions are strongly linked to physical health. So again, if we want our kids to be healthy, we have to attend to emotions. Kids with good emotional regulation score higher academically. They get along better with their friends and siblings. They have fewer behavior problems. They're less prone to aggression and violence. They're more positive, and fewer negative feelings. Again, what I'm going to tell you in your marriage, in your parenting, for your child, there's actually... we tend to spend a lot of time trying to reduce negative emotions, but that's not as predictive of outcomes long-term as positive emotions are. So if you look at like happily married couples and those that divorce, actually how much they're fighting is exactly the same. In couples that survive, there's 5 times as much positive emotion in the relationship. I just recently did a study of healthy siblings of kids with Prader-Willi, because we're seeing a lot of trauma in the siblings in our clinic. And when we were looking at psychopathology in the healthy siblings, again, it wasn't, we asked them to fill out how much in the last week have you experienced these positive emotions, and how much in the last week have you experienced these negative emotions. Our healthy siblings who were doing well versus those that were kind of struggling, and who, gosh, over half of our siblings met criteria for PTSD. What differentiated the group that was healthy from the group that was struggling psychologically wasn't their negative emotions. They were as frustrated, as annoyed by their sibling, as jealous, as whatever. It was how much positivity they had in their lives. And so it's nice because sometimes we feel like, I don't know how to take away your anxiety or your sadness, but what we can do is add joy, add delight, add surprise. Find those things that give you that moment of happiness, right? It's fleeting, but that moment of a giggle can actually be very, very protective for yourselves, for your marriage, for your healthy children, and for your children with heterotaxy. And again, kids who are aware of their emotions, don't suppress them, but know them and regulate them, are more resilient. So your kids are still going to feel distressed, but they'll bounce back quicker, even after major life events. Okay. Okay, so what is the risk? This is where I'm going to just draw on the general literature. We know that children with chronic illness, and again, the groups that have been studied are kids with congenital heart disease, who's probably their closest proxy, right? Children with CF, with diabetes, with epilepsy, with cancer, they've been studied out the wazoo. Kids with HIV, kids with, did I say diabetes? So that's where a lot of these data come from. So if you look at a mixed group of children with chronic illness, they're at heightened risk for psychiatric disorder for all the reasons I've already said. And it's about 4 times the risk of a healthy child. So it's a substantial increase in burden. Our best estimates, and this is almost true across illness groups. So it's about the same in HIV as it is in cancer, as it is in CF or diabetes, or even headaches and asthma. I mean, I think sometimes we think like, oh, psychological adjustment is going to be worse in cancer than asthma. It's actually not. So in general, almost across all illness groups, it's about a third of kids that with chronic illness that can be diagnosed with a medical illness and a comorbid psychiatric disorder. Now, that's like official diagnosis. Certainly a bigger percentage than that will have subclinical symptoms, so some anxiety symptoms, some symptoms of depression, but not enough to kind of cross that threshold to a diagnosis of major depression. So, but about a third will. And again, the rates are typically like 28% to 40%. And it depends like how much cosmetic impact there is, how much pain there is, potential for mortality, those kinds of things. What breaks my heart, and again, I think of this kiddo that I worked with this week when I was like, where was our team for the last decade, is fewer than a third of children who have a diagnosable psychiatric condition in addition to their medical condition get services. And I don't mean that in a judgy way. Again, I think it's that sense of, I've got to deal with all these things. I have to put this over here. But if we look long term, those kids medically do much worse. And so, again, I will get off my soapbox, I promise. But I'm like, if I can give one message, it's like, if you're worried, reach out. Like, reach out. It's, you know, if it's a short intervention or the psychologist says, your kid is actually fabulous, great, then you're done, and they can talk to you about why you were so worried, you know. But we err far more on the other side of trying not to see that my kiddo is struggling in the world, and it just kind of breaks my heart. So in terms of when I say psychiatric disorders or psychological concerns, internalizing are far more common in chronically ill children. They're more likely to be anxious and depressed. Those are the big two. Unfortunately, if you look at what are the psychiatric disorders that parents become aware of and doctors become aware of, it's not these, okay? We tend to the doctors don't see it very often. They're not good at identifying anxiety and depression in children unless they give them a measure, a questionnaire. Because it's in the child's head, right? Now, where I see it is the kids who are panicking and fighting the nursing staff. So we had a cute conversation yesterday with a little boy who was melting down in the PICU. And, you know, we were like, you can scream, but you can't interfere with medical care. And he was like, can I pinch? Like, no pinching. You can pinch your pillow, you can pinch yourself, you can pinch your stuffy. You can't pinch the doctors and nurses, especially the nurses. You know, can I kick? And we're like, you can kick unless we're trying to get a line in you. And then it's interfering with like, he was like, he's going to be a lawyer. He was like, give me the parameters of what and when I can kick, you know? So it's like, you get to feel mad, you don't get to interrupt medical care. So that we're really good at identifying, right? Like, it's there. Unfortunately, that's not the most common. Externalizing disorders in kids, so ADHD, problems with aggression, those kinds of things, their biggest risk is they affect adherence. And it makes sense. If a kid is acting out, that they're going to be like, I'm not doing my PT. I'm not taking my meds, right? But, and depression and anxiety depression can interfere, especially with adherence. But again, internalizing are the most common. Anxiety, so what the literature shows is like anxiety is more common in kids with cystic fibrosis, migraines, sensory impairment, and epilepsy. What I would say to you, and this is again Laura, so take it grain of salt, right, is that when kids have had, what I see is when kids have had a threat to airway, they're much more likely to have anxiety, right? That the reason kids with CF is they may have had choking episodes, but they also have been gasping for air. And a panic attack and your lungs shutting down are very, very similar. The other kids I see it in are my kids with pacemakers who feel that kick and are aware their heart stopped beating for a minute. And when you're little, it's when you're big, right? It's actually high rates of anxiety and depression in adults, post-heart attack and things like that. So what I would say is severe pain, threats to the airway, and then again, when kids can feel strong activity in their heart or chest, that anxiety is much more, because it's the same symptoms of anxiety. And it's, again, that's just fight or flight for survival. If you can't breathe, you can't breathe. Let's see, eating disturbances, whether it's anorexia, whether it's bulimia, or something called ARFID that I'll talk about in a minute, are much more common in kids with GI involvement. Again, because eating has been unpleasant. So other than it's not fun to be depressed or anxious, why do we care about comorbidity? It affects quality of life, it affects educational and occupational attainment, and it affects health, right? So as we look for what we wish for our children down the road, we want them to do well in school, we want them to have careers that are meaningful, we want them to be healthy enough to enjoy their lives. So comorbidity, it's not just that thing on the side, it pulls everything else down with it once we have psychological concerns on top. Here's another one of my patients' drawings. When I asked her, she was admitted, probably her third time in the year, and I asked her to draw what she was feeling, and this is what she drew for me, right? And again, it's just so striking that that little body is being surrounded by monsters on all sides. Sadly, I'm one of those, right? But I think, but I'm not the three-headed one. I'm not. So right, and I really do think this is my kiddo's experience of the medical team, right? I was like, guys, this is us. We are all coming at her with our claws and teeth bared and our many, many eyes. I think this is the attending and the residents is my hypothesis. I didn't ask, but all these eyes and heads looking at you, right? But I think, again, what sometimes kiddos can't put in words, their images are so striking of their inner experience. When I said, how do you feel? This is how she felt on her day of admission. We hadn't even actually done anything yet. I knew she was coming in, and so I kind of met her up on the floor. Also, like my 4-year-old who was asking under what circumstances that he could kick, I just remind parents, RAR means I love you in dinosaur, because you're going to be the brunt of the RAR from your kids, right? When their little inner dinosaur comes out, you unfortunately are like the rabbit. Just remember, it means I love you. So why are our kids more vulnerable? Well, they've got a loss of control over like everything, right? They've got a loss of control over their environment. Do they get to be home, or do they get to be in school, or do they have to be at the clinic? Do they have to have, CPAP at night? Do they they can't control their environment, what's happening around them. They can't control their own their own bodily integrity, right? People and things are coming into their bodies all the time. They don't even get to necessarily have much control over their routines. We say, okay, you're going to get up and you're going to take these medicines, and then you're going to do your RT, and then, so playtime is, for example, can be again, that thing that gets pushed aside, and yet if we know what do kids need, they need to play. So there's this profound loss of control. And I would say, my kind of parenting advice to you is to constantly be working with your kids from very, very early. What do you have to accept that you just don't get you don't get a choice over if you take your medicine? That's just not a choice. You can take it now, or you can take it in 10 minutes. But where do you have choice? Where do you have control? Where can you exercise your agency? And making sure that you mentally are carving that into your kiddo's day every day. Maybe they choose the dinner. Maybe they choose, okay, these are the times we won't be able to just have downtime, but here's the rest of the day when, let's make sure you get time to just do whatever. And so as parents, when we have kids with medical illness, you have to be nurse, psychologist, parent, teacher, educator, community activist, like your list of taxi driver, your list of responsibilities goes on and on, but you also need to be like that best administrative assistant out there. We do know that the more organized a home is, the better the child does. So having that planfulness, and again, you're probably thinking, Laura, do you know what you're asking? But if we just kind of hold it in mind, it's more likely to happen. Again, our kiddos experience unpredictable events a lot, and sometimes they're life-threatening. Most healthy children, their lives are just more predictable. By the way, as I talk about trauma, this is also true for your healthy sibling. As they're watching these unpredictable medical crises evolve, life just feels scary and unpredictable, and things just, it's hard to feel on solid ground. You probably know that more than anyone else, right? It's hard to feel on solid ground. They're distressing medical procedures, social anxiety and unbelonging, I think, and it's honestly just one more kick in the pants with heterotaxy is that, in CF, let's say, there's still lots of variability, but there's more similarity patient A to patient B. Okay? And so if you have heterotaxy, first of all, the people are like, never heard of it. So you feel different than your typical kid without that situation. But you also may feel different than other kids with that medical condition. And you feel different than kids with other, it's hard to find another, right? Which is why conferences like this are great. But what I find is that our kiddos are hyper vigilant about, but I have GI involvement and they don't. Or I've had 17 surgeries and they've had 12. Or, and it's because, again, a little kind of combat humor in some ways, but it's also that child has gotten so attuned to going, but, you don't know, you haven't been. And so I think really cultivating from an early age, I have a cute little guy who was born without genitals, has some congenital defects. And, his mom, from the time he was an infant, said, I want to see you every 6 months so that when this comes up when he's 16, he knows you and he's not having to meet you. So I he's 5, he's happy, he's healthy, he's like this great little kid, and we just play every 6 months. So that should he ever... and so one of my favorite little sessions with him was, he was like, you're a girl, you don't have a penis, right? And that's a very typical 3 or 4 year old as they're figuring out. And I was like, that's right. And he said, I'm a boy and I don't either. And I was like, that's right. and that, because his parents had from the beginning been like, we're all different. I can eat this, I can't eat that. I have a peanut allergy. And grandma lost her breast to cancer. And, and it was just like, he was like, but we both like Hot Wheels. And I was like, that's right. And for him, his genitals and Hot Wheels were on the same plane, right? Which is great. From my perspective, I'm like, fabulous, I didn't have the cool red Hot Wheels or testicles, and it was like, but he at least had the red Hot Wheels. And it was just part of his world, that we're all different. And his mom had worked really hard at helping him find connections and say, here's where we're the same and here's where we're different. Because it is an uphill battle, that sense of unbelonging, right, and that social anxiety. Interestingly, he lived in this really rural area, and he had another kiddo with a really similar medical condition, and they were the two that went to the school nurse together for their G-tube feeds and, and with help changing their colostomy bags and things like that. So his mom was really good about intentionally creating a sense of belonging. The other thing is that there's this perceived fragility, which makes 100% of sense because your kids have been really fragile at different times, right? The problem is sometimes kids don't recognize you were at death's door and now you're not. And you were an exceedingly fragile baby, and now you're a pretty healthy kid. It's hard for them to make that transition because they've grown up in this context. And it's hard for us, with all we've been through with our kiddos, to start to let go a little bit. And so part of why I think we see more anxiety is kids grow up with this sort of unspoken of careful, 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 right? And so what it's doing unconsciously is it's telling the kid, you might not be able to handle this. You might not be able to handle this. And so it can even be then things that are simple. I always say, like, to my families, like, living with a chronic illness, it's like going on a hike with a rock in your backpack, a stone in your pocket, and a pebble in your shoe. And lots of times what we're focused on is that big rock, right? This extra burden you're carrying. But sometimes it's the pebble that knocks the kid off the trail, right? It's that daily little rub. It's the daily shot, or it's that thing that maybe we're not talking about. It's one more poke, one more lab draw. And we're like, holy cow, you got through open heart surgery. Why are we freaking out about a blood draw? Because that's the pebble in the shoe. And so sometimes our kiddos who've been through so much medically throughout their lives, they have a hard time being like, we can sit down and try to get the pebble out of the shoe or shift it or whatever. Because again, of this sense of I don't have control and I'm vulnerable. So sometimes when kids can act on their own behalf, they don't. And then there are medication effects. And honestly, it's the first thing, when I got a call this week from nursing saying, you need to come see this kid. They're driving me nuts. Well, they're on super high doses of steroids. And I'm like, there's only so much tucking and drawing is going to do when you've got a kid really rubbed up on steroids. And we can look at medications to help manage the irritability that's coming with the steroids. But also we need to look at, like, is this an adjustment issue? Is this burgeoning depression? Or is this a side effect of their new medication regimen? And those are questions that I think it's why interdisciplinary teams are so important, but to keep asking your mental health providers, could these behaviors, like, again, we have a kiddo in the hospital right now, when his ammonia levels he's Jekyll and Hyde, and it just rides on his ammonia levels. Whoa, almost lost the coffee. So, like, trying to figure all that out, it's why not everybody has the luxury, but if you're in a big city and you can see a medical psychologist or a pediatric psychologist, I think it's helpful because we're always dealing with medication effects, whereas maybe a mental health provider who's more generally trained in the community may not be thinking, could this be a side effect? And then there's the physiological effects of the illness. Your kid might be anxious because they're not breathing well or because they're feeling something's off, and their internal radar's going up. So again, it's making sure that we don't dismiss the anxiety. It could be medical, it could be psychological. We have to attend to it. Okay, so what's depression? We use it all the time, but it's sadness, irritability, more often than not. So if you're a kiddo for 2 weeks, it's a very low threshold. 2 weeks of more days than not, so 4 or 5 days a week, more than half the day is feeling sad or irritable. And in kids, it more often presents as irritable. In adolescents, it more often presents as sadness. Anhedonia is loss of interest in those things you like. So it's like, let's go, play Frisbee, and they're like, I don't want to. Or let's do arts and crafts, and they're like, I don't want to. It's just, not fun anymore. Sleep disturbance, appetite disturbance, excessive guilt, thoughts of death, and hopelessness. Now again, sometimes we have to be really thoughtful in our assessment of this because sleep and appetite disturbance can be a medical side effect. So maybe they're depressed, maybe they're not, right? And that's a question we get in the hospital all the time. Are they not taking their meds because they're depressed? Are they not taking their meds because something else is wrong? What's going on? So that's what we're talking about with depression. And again, when I asked one child to draw their experience of depression, on the left here, it's kind of a light drawing, but this is like a flesh-eating monster emerging from a cliffside. So see the teeth kind of sticking out? And so I was like, well, if I stay here, I'm going to get eaten, so I might as well jump. And so it's just that sense that there's no escape, there's no hope. I'm either going to be eaten by the rock monster, or I can throw myself off the cliff and see where I land, kind of thing. But that sense of there is no safe place to turn. In anxiety, what we see most often in kids is just generalized anxiety. I have kids talk, I go in and I ask them about worries, and I'm expecting to hear about health, and what I hear about is their worries about their parents' finances. Because again, our kids are smart and they're listening, and and medicine is unbelievably expensive, right? So they could be worried about, again, I might go in a medical crisis thinking this kid's afraid for their own health, and they're actually worried about their sibling, and they're worried about how their mom and dad are going to pay for this, and they're worried about if they're going to get sicker, they're worried about the school they're missing. So I think I'm often humbled and astonished that the things that I might think I might be worried about or anticipate the child being worried about, they're actually worried about like way different things, right? Or they're missing some kind of social event and they're worried about if that friend will still be their friend. Separation anxiety is much more common in our kiddos with chronic illness, but I would say separation anxiety is also more common in our parents with chronic illness, right? That fear of, if I step out of this room, what if something happens? So again, very bidirectional, very understandable, gets in the way. And again, I see it, so typically we think about separation anxiety in our toddlers, but I think when you've been through what you've been through as a family, it can persist. Like I have a lot of school-age kids who miss a lot of school because they're like, what if I get sick at school? What if I have a crisis at school? And so they have a very low threshold for coming home, and they have a very high threshold for leaving home. And as parents, sometimes we are like right there with them, right? And so how do we help promote functioning and not, because anxiety is strengthened by avoidance. So when you avoid those things that are scary, the anxiety gets higher. The more you work through it, the more the anxiety goes down. And I think lots of the families I work with, it's like, okay, well, what's a reasonable fear, right? So I had one kid say, I want to go on a humanitarian trip in Africa. And mom was like, I'm scared. And I'm like, with good reason, there's no medical care there. If something goes, like in this particular place that he was going on the humanitarian trip, there wasn't going to be medical care. So to me, that was like, there might be a little wisdom in not going there, right? What's another way you can make the world a better place? The other things we'll see again, panic, and then I'll talk a little bit about trauma. What I'm going to keep saying, though, avoidance is what maintains and exacerbates anxiety, and that's why we want tough, supportive love, right? And that is, you can take the medicine now or you can take it in 10 minutes, is that I know you're afraid you're going to choke. I know you're afraid if you're going to take this, you're going to puke. I know you're afraid it's going to hurt. And I believe in your capacity and my capacity to handle that if that happens, not to just keep putting it off. What I will tell people, when you put it off, anxiety grows. It just gets, anxiety tends not to stay flat. It tends to go down and get better or grow, right? And so I think in every moment, what I'm going to talk about as you as emotion coaches is, what are you teaching your kid? Because every moment is an opportunity for learning. Right? And so are we teaching them, you're right, you can't handle this, you can't go through one more thing, or shoot, I hate everything you've been through, and I also believe in your ability to be resilient. I'm going to skip this one, but if your kiddos have issues with, again, it's very common for our kids to be underweight because eating has been painful, because they've had emesis, for a variety of reasons. I think sometimes parents will say, my kid doesn't have an eating disorder because they don't have anorexia. They're not afraid of getting fat. They're afraid of eating's going to hurt. They're going to get constipated. They're going to vomit. We actually see, again, anytime GIs kinds of issues are involved, we see these higher rates now of a disorder that kind of emerged and can be diagnosed in kids and adults and adolescents in the most recent iteration of the diagnostic manual in psychology. But we have kids who will avoid food because I have a number of kids who avoid any food that's ever had medicine in it, right? They used to love applesauce, then we started breaking pills in applesauce, and applesauce is out. So's yogurt and ice cream, and right? Any food they've ever puked is out, and all of a sudden we have kids with this narrowing range and repertoire of foods that they'll eat. And often what I see are kids who eat what I call white and yellow foods: chips, breads, noodles, chips, desserts, right? But I'm having a really hard time getting anything with color, any fruits, any vegetables, and I'm having a hard time getting protein in that kid. And so we start getting nutritional deficiencies, which can cause health problems. So again, I think this is one thing that I see that parents can back burner and doctors can back burner, but we know our kids need healthy bodies. So if you're concerned about eating, I would just say talk to someone about it. All right, so what can you do? Most of all of us are focused on the biological piece. You're making sure they get their medicines. You're making sure they get to their treatments and their appointments. They're getting their therapies. But what I would say is it's in the spaces in between that, which is where most of life lives, right? And the spaces in between those treatments are where we're going to really help our kids on this cognitive and emotional end. Again, you have a role in their functioning. You have a role in their relationships. But I just want to focus on these for... I'm really not good at PowerPoint. I was so excited by that one. Okay, so emotion coaching, maybe one of the most challenging parts of parenting, right? And one of the most important. And I love this quote by Aristotle. Anyone can become angry. That's not hard, right? That's easy. But to be angry with the right person, to the right degree, at the right time, for the right purpose, and in the right way, that is not easy. It's hard for us sometimes, right? Think about that nurse you wanted to punch, the doctor that you wanted to kick because of the really lousy way they delivered information to you or spoke to your kid. And think about all the times your child screamed again at the wrong person for the wrong reason. We've all done it. But this is one of the things that if we can help our kids master this, you have done a fabulous job of parenting. So how do we help them recognize and regulate their inner lives? Again, I just want to say a million times, like there's nothing wrong with being anxious, right? If the rabbit weren't afraid of the fox, we wouldn't have rabbits. Emotions serve us. They're just one more point of information. And so I want your children not to ignore their emotions, but to learn to use them, to say, what am I feeling and why? How can I use it? And in psychology, we talk about this when there's actually really cool evident, like from folks who've had brain injuries, that if your emotion centers are wiped out and you don't actually feel much emotion, but you're very, very rational, you make terrible decisions in life. It's really interesting. We all think like, oh, if I could just be more rational. It's not what the data suggests in people who've had these really funky brain injuries. We need both. You know that like go with your gut, like something about this feels wrong, or wait, I need this medical procedure to slow down. Something's off with my kid. You know, we need that. So our emotions are much more rapid. They activate us for action, but they're sloppy. And so we need to listen to them. It's like the canary in the mine, right? We need to listen to them. It's a really important indicator, but we need to slow down because our emotions are like, go, right? My little 4-year-old, I got a kick, right? Like scared, angry, kick, and it's go. So we have to it's a very adaptive first response. We just have to be able to reflect. And that's when we kind of, as parents, get our emotional minds with our rational minds, we get this wisdom. I know you probably don't feel wise on a day-to-day basis. That's also what we want to help our children with. A lot of the kids I work with can't tell me, are you sad? Are you anxious? Are you in pain? Are you hurting? It's really important you give them that vocabulary because that sometimes, like, you know, I had a kiddo who said, I'm not scared, but I'm confused. And she actually was developing a infection in her shunt. And she kept saying, like, something's wrong, something's wrong. And we could listen to that, right, before things really plummeted. By the way, this is not for chronically ill children, but this is just in the literature about children's emotional development. Dads may be the most important players in this. And it may be because moms do it so much that when dads do it, it's like, whoa, right? We don't actually know why. That's again, Laura with a grain of salt. But what the data show is dads may be the most important player in emotion coaching, and dads' responses emotionally tend to make a situation much better or much worse. So helping our fathers, they make a bigger impact, right? It's just a bigger impact, and it can go either way. But making sure dads are involved may be really, really important on the emotion end, not just again, 90% of my parents that bring the kids to see me are moms. There are a lot of reasons for that, but a piece of it is, like, the emotion work is often the mom's work. So just asking yourself, what kind of emotion coach are you, right? So this is Gottman's work, who did a lot of work in marriage as well. But there are kind of 4 ways parents respond to emotion. Dismissing. That didn't hurt. You're not scared. You've done this before. My mother-in-law, God love her, is put that mat away. Put it away, put that away, we don't need it, right? And that is like, there's no room for emotion here. She then gets out the chocolate cake. Put them out away, let's eat. So dismissing is, that didn't hurt, that wasn't scary, it's just like, poof, right? It's often not meant to be mean. It's just like, this isn't a big deal. For the kid, it may be a very big deal. That may be the pebble in the shoe. Again, if you've ever hiked with a blister, you know that pebble can be tough. Disproving is expressing negative affect at your child's affect, right? So the child gets anxious and you're like, knock it off, right? You get upset if the child shows anger, sadness, pain, or fear. Now, you know why that's important? Because what the data show in chronically ill children is their physical symptoms go up in families where their emotional expressions are punished. And what I would say in a medically fragile kid, it's really important for us to tease out when is something tanking physically, when is something tanking psychologically. So if they're not allowed to express their emotion, they tend to have more pain and more disability, go to school less, need wheelchairs as opposed to walking, those kinds of things. So super important. Laissez-faire is just, it's like, whatever, you cry, you scream, right? And again, it's the parent that says, yeah, kick the nurse, I don't care. Like, I just cannot fight one more battle, typically, is the attitude. Where like all emotions, again, remember that Aristotle, right person, right purpose, right way. This is like, yeah, whatever. You want to rip out your NG tube, go ahead, so what we really need are emotion coaches, is what we know is related to the best outcomes. So be aware of what they're feeling. Recognize, because most of us, we're at our wit's end, right? And so when our kids' emotions come up, we're often like, oh, I cannot do this right now. I do not want to ride this emotional storm with you. But that's, and I think a lot of us want to kind of lean back, like, you have that moment, and right? But this is the moment to lean in. Your child's emotions are your best opportunity for intimacy, connection, and teaching. So we want to listen, we want to validate, we want to label the emotion, and then we want to set limits, right? Again, you can be angry, you can't interfere with medical care, but we want to help the child problem solve. And this especially, again, once your kid is 5 and older, be like, how do you want to handle that? Now, they may not have good answers right at 5, but we're starting to set the stage of, what do you want to do? How do you think we can respond to that? What would be an option? What do you want to say to your friend? What do you want to say to your doctor? So what we use as kind of our acronym in the hospital is set your kiddo up for success. Support, empathize, and then truth is like, yeah, but you can't kick the nerve, right? You can't, like, the truth is like the limit setting place. So yes, you're angry. I get it. You have had 4 procedures this morning. You're tired, you hurt, and we still got to do this one. And then just being really understanding that for however hard it is for you, remember, your kids don't have the resources we have. They don't have the intellectual resources. They don't have the life experience. They don't have the emotional resources. Brain development goes on to 25 in young men, right? So when you feel like you're tapped out, your kiddo had fewer resources to begin with than you did. So being understanding and not giving up. So really, if we think about, in my anxiety, by the way, I always over-prepare. Sorry. So when we look at the data on resilience, and this comes from lots of different places, whether it's the pediatric literature, it also comes from some really interesting studies by the Department of Defense with Navy SEALs, because it takes a kind of special breed to be a SEAL, right? You got to be able to manage real adversity on the fly. When we look at folks who do well in the world, one is competence. And so we want, from the beginning, to be teaching our kids all the skills they need, whether it's managing their medical condition, academic skills, social competence, right? It's okay to say to your kiddo, wait, try that again. Say that to the nurse in maybe a kinder way, you know? Building confidence that they can do things, building connection, which is, again, what's great about this conference, character, making sure that your child is making some kind of contribution to the family, to others. That's where having a sense of I'm not, again, when you're the one who only receives, so again, babies and toddlers should only receive, right? It's like, that's the time of life. But once they get older, you know, you can help me wash the vegetables for dinner. You can help us make dinner, whatever. Teaching our kids active coping and giving them control where they can have it. Those are the elements of resilience, the 7 C's. Okay, so what can parents do? Be a teacher and an advocate. We were talking, lovely Ms. Monroe and I were talking about those moments when she's let her daughter know, I'm struggling, right? This is actually hard for me and harder than it looks, because then your kid gets to see, like, oh, 1, I'm not the only one who struggles, but 2, like, how's mom doing that, right? How's mom doing that? So what are we teaching about, here's how you talk to doctors and nurses, here's how you advocate, here's how you say, because again, in hospitals, we are moving 40, really, really fast. It's okay to say, stop, wait, I just want us to talk about this, or I want to understand this. We have questions. So how are you teaching your child to advocate in the world? And unfortunately, you do have to teach your teachers, and you have to teach your therapists sometimes, because they won't know what heterotaxy is, and you have to teach your doctors, and you have to, you're teaching a lot. So how do you cope with that is you have to balance problem solving with letting go, right? It's as important to take care of our emotions as it is to problem solve, and that's the piece. Again, if we look at their literature, folks who overemphasize one, who are all about like, okay, I'm just going to have some marijuana and some alcohol and take a nap so I feel better, but they aren't problem solving, they don't do well in the world, right? But the people who are like, I can solve everything, let's go, problem solve, and aren't taking care of their emotions also don't do well. In chronic illness, we find you need about 50%. 50% of problem focused, 50% of managing emotions for you and for your kiddo. So teaching yourself and your child that. Again, every moment's a moment to teach. Let's see. In terms of our thinking, the more the child believes in powerful others and chance, the more panic, OCD, social anxiety the child experiences, right? And so what we want to do, this external locus of control, it's up to someone else, tends to promote anxiety and worse quality of life. This is another one of my kids' thought from therapy. This is her head right here. And I said, what are you thinking? And she said that. And she really was like, well, there's nothing I can do. And then sometimes, like for example, religion can be really linked to better outcomes. But sometimes when kids hear, well, it's up to God, they feel, depending on their age, that message can or might not be heard as well, right? It's like, well, God smites things sometimes in the Old Testament. Like, it's scary, right? Or it's up to the doctors, or it's up to chance. But I think if we say, look, I don't know how this is going to turn out, but what you can do, here are the things you can do to help yourself feel better. Or here's how we can spend our time while we wait. Those kinds of things are helpful to our kids. All right, so just a few more, and then I'll take questions. So why go see a psychologist? We do more than just say, and tell me how that feels. Okay, although my kids think that's all I do, that I play Barbies and say, tell me how you're feeling. Mental health providers in behavioral medicine can help your children with pain management. I think there's a lot of focus on, there's a great, if you've watched or listened to the podcast Invisibilia, the first episode is fabulous for because with the opioid crisis in the United States, everybody's saying, like, what can we do for pain that's not an opioid? And so the first podcast of Invisibilia is really good about that. But there are lots of things we can do actually for pain management. You will need to help coach your children to actually practice it at home. We can help kids increase functionality, work with schools, create 504 plans or IEPs so that we try to have kids in school as much as possible, functioning at their top level. We can help kids with coping skills. We can help with grief work. I'm not going to spend a lot of time today talking about grief, but this is a community that loses children, right? In oncology, again, we have wraparound care and we have SOAP teams, supportive oncology teams, that help kids cope with the death of their friends. When kids go to camp and their friend doesn't come back to that camp the next year, or when they've learned that person they met at conference has died in the air. There's the grief piece for the child, but there's also the could that be me piece for the child. And so helping surviving siblings, surviving friends, parents with their grief. Again, if your child's the one that survived, they still might be experiencing grief from their friends who didn't. We offer marital and family therapy, suicide assessments, treatment of psychological disorders, how to help our kids, especially in the adolescent years when they have to take increasing responsibility, right? Like, so our pulmonologist last session was saying kids don't want to go to college lugging a big vest, right? But some kids, that's what they have access to. So how do we make sure they're doing the respiratory therapy when they are in college? Assessing neuropsych testing if your child has ever had an event where they've been hypoxic or had, again, a lot of our kids can have some kind of impact on brain because of all the surgeries and things they've been through. So we see higher rates of learning disabilities and ADHD and things like that. Treating trauma, we can help be advocates and care coordinators. I have parents who know much more than I do, but they say it to the school and the school hears an overprotective mother. And then I say the same thing and they go, oh, Dr. Murphy, okay. So don't be afraid to invite your person who has a credential. And even if you have a credential, as many of you do, they'll still see you as mom. My kids' teachers see me as mom. And then some of our kids go on to develop somatic symptom disorder, which is lots of bodily concerns beyond what we can explain medically. So pain beyond what can be explained medically, impaired function. So it's not that it's in your head, but we see a lot of kids who get this heightened pain response or this heightened sensitivity, and the doctors are saying, look, given what I'm seeing on all these tests, they should be functioning over here, and your kid isn't. They're having a lot of more symptoms than I can explain. It might be a somatic symptom disorder, which is a psychological outcome of sometimes having medical conditions. So my approach to treatment and my approach for parenting is, yes, we have to reduce the risk. If your kid's anxious or depressed, we got to cut these big vines that are choking out that tree, right? We got to cut those back. But the tree's not going to survive without sunlight, water, good soil. And so we need to reduce the risk, but we need to build the resilience. And that's where I think as parents, you're building the resilience. You're giving the sunlight and the soil. Okay. Let me just, these are several slides that just say our interventions work. Like, they're actually data that show kids who get therapy do better than kids who don't. Okay, my anxiety, sorry. A couple words about medical trauma. Medical trauma is not exactly a diagnosis, but it's a set of psychological and physiological responses of kids to pain, injury, illness. It's really common if you've been in the ICU ever, okay? And this is, again, that's the worry monster that a 7-year-old little boy that I worked with drew after he'd been in ICU and then rehab. And his anxiety was always watching him. It's got 5 eyes. It had a buzzsaw belly, right? And it could bite him and swallow him up with its big mouth. So he just always, like our little girl in the middle of those monsters, he felt attacked by his own anxiety. It's an interesting phrase, my anxiety, my depression, my trauma. I really try to get kids to eliminate it. We can treat anxiety. It's not a part of you that's going to be with you forever. Depression, trauma, same thing. You might have symptoms of trauma. It doesn't mean it's yours to hold on to and protect, right? Like your teddy bear. But this was his anxiety and how he experienced his symptoms. So I always think this is fascinating. Most of the research in medical trauma comes from the ICU or from oncology. Ann Kazak at CHOP does a lot of this work. But about 1 in every 5 kids will experience trauma. What's interesting to me is the child who's the patient actually tends to have the lowest rates of trauma. Parents, so we have 24%, let's say, of teens with cancer, but almost 30% of siblings of teens with cancer, 45% of moms and 35% of dads will meet diagnostic criteria for PTSD. So I think we put all this worry into our ill child, and that makes sense. Again, 20 to 25% of our kids may have trauma responses. It's more likely everyone else in the family that's had to watch it, right? Sometimes the scare, your kid's on ECMO, they're unconscious. You're watching that monitor. You're watching the desaturations. You're watching it, and you're helpless. So, again, very cliche, but on the airplane where they say put your own oxygen mask on first, because if you pass out, then you don't have oxygen and the kid doesn't have oxygen, right? Like, be aware of yourself because it's going to affect all those other things we've talked about. Okay, why? Because childhood is supposed to be playing and safe and fun and loving and snuggling, right? None of us kind of imagine when we're pregnant the journey that we're going on. And so it challenges the child's belief about the world. I had a little kiddo ask me, he was like 4 or 5, and again, in the ICU, not breathing, and there was concern he might not survive. And he said, God, I love preschoolers. I love them. He said, Dr. Laura, did I smoke when I was a baby? I was like, no. No, you did it. Mommy wouldn't let that happen. No toddler cigarettes. No, you were good. But because their understanding of what's happening doesn't make sense. And all he knew was people couldn't breathe and died if they smoked, right? He'd seen his public service ads. So those preschoolers who have cognitive limits and what they can understand, we have to provide a lot of, but the truth is a lot of what's happening in our family challenges our beliefs about what life should be like, right? There is a sense of threat. By the way, this is an important part in trauma. You might know your kid's not dying. Your kid might not know that. It doesn't matter if their life was truly at risk or if someone else's life was truly at risk. If they believe it was, that's the traumatizing part. It's that subjective belief. And again, you don't rationally talk someone out of that. If in the minute, right, so if somebody came in here with a gun to rob us and we thought we're going to die, and later we found out, oh, that gun was plastic and there were no bullets in it, it would still be traumatizing, even though we weren't actually in danger because we believed we were. So understanding how your child is thinking about things is really important. Also, know that kids in the hospital are hearing the kids next door screaming. They're seeing the code across the hall, and they're watching the team rush. And so it may not even be about them. The things that are traumatizing can be about someone else. And I will also say, your child may have symptoms of trauma and not link it up. So I was treating this really dear 18-year-old boy who was getting ready to go on his mission for his church, and he had terrible phobias about needles and blood. And he was like, isn't that weird? But he was really sweet because he was like, I don't want something to happen when I'm on my mission and I can't respond because I get, he'd passed out in health class, he'd passed out in driver's ed when they, anytime he saw blood. And he didn't want something to happen on his mission where he wouldn't be able to function. And he was like, sweet boy, that he was like, I want to be present at the birth of my children. I don't want to be passing out when my wife is in labor, So we were working on it. And he and his family didn't connect, but this was a kid that had 15 surgeries before the age of 10. And he didn't remember much of it, right? A lot of craniofacial stuff. And a lot of he didn't remember it, but he had these, literally his body would just collapse. And of course, his teenage boy friends were merciless. But, any picture of a needle, and he was flat on the floor. And he didn't link that to his early experiences. But lots of things can be scary. And again, once pain is involved, when you've seen other people get hurt, and then again, as you know, you're often required to make these major decisions in the time when you are the most vulnerable. You are sleep deprived, you are terrified, you're in distress. So this affects our kids. So again, this might seem cliche, but I'm just going to end with these 2 pictures. You are your child's safe port in the world, and that's beautiful and terrifying, I think, for lots of us, right? The reason why, these are pictures not from, again, Heterotaxy, but this is after the attacks of September 11th. And these were two children that were in the daycare across the street from the World Trade Center when the planes hit and the towers went down. And those kids, I don't know if you remember, but they were evacuated out of the city. They walked out in little duck lines, were put on barges and sent out into the bay because we didn't know if more attacks were coming. So they hear the booms, they see the fires, they see people jumping. They have to run through the smoke and the sirens. They're on barges. They don't know where their parents are. It took hours to reunite those kids, right, with their parents. So these are like the stories we didn't hear necessarily of September 11th. So I have a colleague in New York who followed those kids afterward, and these pictures are actually published. But this was one kiddo who was asked to describe that day, and this was their drawing. And what this child described is, this is the building on fire, and these are the people jumping out of the building, and this is the bed, and my mom's asleep, and she's dreaming of the fire, and I'm burning up, and she's dying. And as you can see, it's full of threat, but it's also full of confusion. Is it the building? Is it a bed? Are other people dying? Is mom dying? Is the kid dying? For the child, it was just this emotional, traumatic, confused, threatening, everyone's in danger. And it's what you see is that breakdown in thinking and that breakdown in emotional processing. But this mom was not doing well. She'd lost people in the attacks, and she was really struggling. Compare that to a child this is the same age. The other thing is, this kid is older. This is a really primitive drawing for a child. This is a school-age child. Here's another drawing. Same school, same age kiddo, years later, who is witnessing the fires. You see the towers up there on fire from a distance, right? He's been able to separate himself. He has these helpful others between him and the danger. So unlike my client, who the medical team was coming in like this, right? This kid has a view of them as being protected, and then holding mom's hand with this cute little golden circle around it, right? This was a child whose parent, in the midst of their own trauma, was able to create a context of safety, acceptance, validation, and hope. Terrible things happen, but good things also happen. And sometimes out of those terrible things, good things happen. And so our gift to our kids is, it's not that this kiddo didn't feel scared, but the child had a chance to deal with those emotions and process those emotions, feel safely attached to their parent, and find a way to cope with the horror that still allowed for hope. And that's where I'll end, okay? And take questions, right?
I would like to ask if you have, what your 2 cents would be in a situation where we know that there are very apparent mental health risks due to family history, due to our observations, but our child is very good at hiding that in front of those who threaten her, as so to speak.
Yeah.
She has a reputation for being like everybody's friend, and that's kind of her strength. That's the one part of her that has not been affected medically. So she uses that to cope. And so then here I am trying to seek help for her mental health challenges and being told that she doesn't need it, or being blown off, or being, oh, she's too young to really worry about that at this point. And as a person that's grown up surrounded by mental health challenges, I can say, no, that's not okay.
Yeah.
Like, where do you go from there?
That's a great, and how old is she? 5. Oh, I love those little ones. So it's like both are true, right? And so one thing that you're describing, I just want to highlight, it's often our strengths that are also our vulnerabilities. So in your child's case, her sociability, her being everyone's friend, her kindness is her strength, and it makes it harder for people to know when she needs help. Sometimes the kids who let you know really easily that they need help, that's a strength, but then people don't want to help them because they're screaming at them, you know. So I think, so I love that you can recognize her strength. I love that it's on your radar. I mean, there are a couple of things, right? We can do things like, for example, pick books in which the character might have feelings and handle themselves well, right? At 5, we want to keep it kind of simple and kind of concrete. So things like How Full Is Your Bucket is a great book, or even just storybooks where there are, like Ramona the Pest or something, you know, like where you can, how might the Boing Boing girl feel versus Ramona? Because your daughter's not a Ramona, she's, you know, someone else. So I think you can do it through literature, you can do it through in the minute, be like, golly, that's interesting because you told me that that was scary for you, but I noticed you didn't tell the doctor, or something like that, right? So often in terms of diagnosis, if it's not impairing, so these kids are the ones I worry about more as teenagers because they're so high functioning, they're so together, and that's beautiful in lots of ways, and it means we miss what they need. So one, the fact that you're aware is like 90% of the battle right there, right? Yay! 2, you keep the conversation going, and just noticing things and talking with her and be like, when do we have to kind of hold together, and when is it okay to show that we're having a hard time, or who are the people in our world we can tell when we're scared. I do these like concentric circles a lot with kids, like our inner circle. Like I don't tell everyone. Like you guys would walk out if I started sharing with you all my, you know, neuroses, right? I don't know you that well. It wouldn't be good for me. It wouldn't be good for you. But I have an inner circle. And then I have another circle that maybe I don't show, but I might say, hey, I'm not feeling great, or I'm feeling a little worried. And then I have people that I don't need to know. Helping her make those distinguishing things, like, you don't have to tell everyone, but make sure you tell mommy or grandma or daddy or your sister or whatever, you know. Like, so kind of helping her in those moments. And my guess is she does great and then has a really hard moment.
Yes, there's always the aftermath, and that's where we see that's what nobody else sees, and it's always the aftermath.
Yeah. Does she have tells that she's building toward the aftermath that you can see?
Sometimes we're learning.
Yeah.
They're evolving. So
Yes. So I think like when you start to pick up on her tells, trying to intervene in those minutes, you know, with the things that help bring her arousal down, so she's not holding together, losing it. I think part of it is, like at 3 to 5 is when kids are really mastering emotional development in a healthy kid. So, like, the emotional turbulence of a 3-year-old is like a tsunami, right? And it's like, whoa, where did that little angelic baby go? Right? So 3 to 5 is when kids are learning social emotions like guilt and shame and embarrassment, and they're also learning pride and empathy. And their emotions are really dialed up 3 to 5, and they're just starting to learn, is this fear? Is this embarrassment? Like they're just overwhelmed and they don't kind of know what it is yet. So she's kind of right on track. Like I would expect, and again, sometimes emotional development is a little bit later in kids if they've had a lot of medical intervention because they didn't have that every day to work on it, right? They weren't at home where their sibling was getting in their stuff. They were in a hospital where they're surrounded by adults who either torment them or give them everything they want, right? So I think like she's right where she should be developmentally. We should be seeing some emotional storms, and you're really in that still teaching stage at 5 of, you know, and again, you can just be like, I wonder if you were feeling worried, you know, and you can just start labeling it. Worried, angry, scared, frustrated. What was it? Embarrassed. What? And again, they may not know, right? They may not be able to say like, I felt like people were looking at me because of my oxygen or something. So I think just starting to give your kiddo a language at this age, and if you're feeling like this is big enough and overwhelming me, then just insisting. And again, finding that provider in your community that you can say, look, I know, because part of it is also the stupidity of the medical and insurance system. If I can't give her a diagnosis, insurance won't pay for it, right? So probably what you're seeing are providers going, this is an adjustment disorder, or this makes sense given everything the kiddo's going through, and overall she does well. But you got to find that provider
left
that
in the
says,
trenches with no help.
Yeah, so you got to find that provider that is willing to work with you, like you just have to keep insisting and asking around. Where do you live?
Texas.
In what part of Texas?
San Antonio.
Okay. So like, and I can kind of work with you, but trying to find someone who understands the medical piece and why it's important and is willing to see your child and say they have generalized anxiety or whatever. Because you're right, you are in the trenches, you're in the every day to day, and you're it's the dinosaur roar is coming toward you. So I think trust your instincts, right? Keep teaching, get help, and we just have to help you find the right person to help you.
That would be great.
Yeah.
So I just wanted to know kind of at what age you would typically recommend. I mean, I know you were talking about the mom that's coming to see you every 6 months, and just to make sure that something doesn't creep up, or just to have an outside view in as well. At what age do you feel like it's the most effective to start?
I think once the symptoms start interfering with function in some way, whether it's school, whether it's getting medical care, whether it's family relationships or friendships, right? Like, so maybe you have a kind of genetically anxious or inhibited, shy kid who then has been through all this medical trauma, and now you see as really withdrawn. And we know, like, you don't need a lot of friends, but you need one or two friends, right? So, like, whenever you start to feel like, again, not everybody needs a therapist, like sometimes.
I feel like I definitely need one.
Yeah. Well, and that may be part of it for you too, is that having a good therapist, you can say, okay, here's what when your 5-year-old is losing it, and they're irrational little creatures at 5, they're delightful, charming tsunamis, like it may be most effective for the parent at some point so that you have someone else to be like, should I be worrying about this? Or what do I do when it's like the 5th meltdown of the day and I'm ready to have a meltdown and I know I'm supposed to be teaching, but all I want to do is choke, right? Like, so I don't know that there's a right age. I think when you feel like this is getting in the way, then it's time to either find somebody who specializes in the young child or who can help you, right? And so I don't think there's a right way. I have parents who they just see me or they see someone else and that's all they need. And they feel like if I can kind of talk this through, I can go back and do a better job. There are others who their kids are in therapeutic preschools because they're like, I'm pretty sure this is a trauma response. I think my kid is traumatized. And even though it's not child abuse trauma, it's trauma. And so like here in Salt Lake, I've got 3, 4, and 5-year-old patients that we just have at the Children's Center in therapeutic preschool, because then they get 3 days a week to work on their emotions and feelings in the context of a supportive other. Some come in just periodically. And I think for that mom, because it was genitals and a little boy and all of that meant, and she lives in a remote place and she's down here every 6 months to check in with cardio and nephrology, et cetera, she was like, let's just have you on board. I don't think everyone needs to do that. I think she was just like, I don't trust myself to know when it's bad enough. Yeah. So I guess there's no right way to do it. It's like, what are your resources? What do you need as a parent? What do you think your child needs? But I would just lean toward earlier rather than later, if that makes sense.
And then for the therapeutic preschools that your patients go to, is it enough that they have all of these other chronic medical conditions to get them in there, or do they really need that diagnosis of anxiety?
So, because our wait list at that particular center is really long, they triage based on acuity. So they would get them on the wait list with the medical stuff and just saying they have medical trauma, even if they don't have a diagnosis, but they're probably going to be on the wait list a lot longer. And the other thing we sometimes run into, like, I can't get kids in there who have NJ tubes, for example, or need G-tube feeds. So this is where families with kids with chronic illness kind of get in a catch-22, because it's like if they're too medical, they can't always get the psychiatric, and if they're too psychiatric, they can't get the medical, and so I know I'm not really answering it in a set. It just really depends on finding a mental health advocate. And I think that's the other thing is, like, when families are in the hospital, they can just say, I want to see the pediatric behavioral health team. And the nice in the hospital, Or even at your like pediatrician, you've got like 20 minutes max with that doctor often, right? Or in the clinics. The lovely thing about my job is I can come in and sit down with you for an hour or two and get a history and get like what's going on, and then we can kind of plan together. And so, for example, here at Primary Children's, we serve 5 states. I'm not necessarily following all those kids, but I can say, yes, worry, no, don't worry. You know, let's find a middle ground, whatever. So I think it's being able to sit down and just talk it through. Here's what I'm seeing day to day, you know, and just talk it through. I don't know. Psychologists are famous for giving really wishy-washy answers. How does that make you feel? No, like kidding. Like it's just hard because if I don't
think about it more.
Yeah, right. The other thing is like I have 4 kids. Like kids vary in their emotional intensity, right? So you have some kids who, when they're sad and mad, they go wah, and then they're good. You have other kids that are falling apart for an hour and a half. Well, if you desaturate while you're crying, right, it may be absolutely fine that you're crying, except you're desatting. And so for that kid, just because they're more emotionally intense, we may need to do more interventions, right? So I have, again, a 3-year-old kiddo that I see who does great, except when she cries, she stops breathing. And so it gets a little, like, there's nothing psychiatric about her, but we have to work with her much more aggressively because she's just really at risk. Like, I mean, blood draws are traumatic, right? Because if she has to get a flu shot or get a lab, she starts crying and she desaturates. So it really, really depends on how much is it getting in the way, how much is it affecting parents, siblings, the kiddo, the health. And if it's affecting you, get help, right? I don't think there's a right or wrong answer. I think if it's causing enough trouble, get help. Get help. My best friend, she was in the New York project. We went to Duke together for graduate school. She's in New York City at Barnard. And we laugh about, like, between the two of us, we became parents in our late 20s. We had over 40 years of training in child development. And, you know, I'd call her at midnight and be like, oh, my kid is doing this. And we were like, how do parents parent? Like, between the two of us, we have 40 years of education in treating kids. And in our own kid, when things are going wrong, we're like, help, you know, you have to have that person. And often it's nice when it's a professional, you know.
Last question back here.
Thank you very much.
So I appreciate the earlier is better sort of mantra. I did have a question. Catherine kind of took that, you know, covered that one at, like, so what can we do? First question, what can we do better as parents? Because I'm personally of the opinion that when you're in the hospital at birth with a chronic condition, there should be wraparound care. There should be psychiatric wraparound care for the family right there. It should be involved. It should be right there. Unfortunately, we know that is generally not the case. And a lot of us suffer through those. You know, I got asked when we were transitioning from the cardiac ICU down to step down, and my son still wasn't doing really well, but they needed space, and they're like, would you like social work to come talk to you? And I'm like, no, I can't have anyone else come to talk to me. I need to watch this kid, you know?
Right.
This is, and that was the last time, the first and last time I was ever offered mental health. My child's 8. My heterotaxy child's 8. So is that something we should be more aware of, cognizant of? Should we be pushing a little bit more for it? And what are the right words we can give our families?
That's a great question. So let me give you the contrast to that. As soon as we find out that a kiddo has been diagnosed, like in the NICU, when we hear a kid's been diagnosed with Prader-Willi, our Prader-Willi nurse practitioner is in and meeting the family. And before that child is 3 months old, they come to our interdisciplinary clinic. So I'm meeting this kid, and I see them every 6 months to a year when they come through clinic, every year. When a kiddo's diagnosed with CF, they go to CF clinic, and you know who's on the CF clinic team? A psychologist, right? When a kiddo's diagnosed with cancer teams, to get funding, to get NIH funding, they have to have a mental health provider. And every child newly diagnosed with cancer, the family is evaluated, every child. They get a neuropsych assessment, they get a psychological assessment, and they're followed. Every time that kiddo is readmitted, the psychologist goes and says, hey, you know, and you know them from diagnosis. So there are all these there are all these conditions where psychology is, we're part of the diagnostic process. We are involved. When there are transplants, often psychology is involved. But if your kid doesn't get to transplant, right? So I do think we need to be talking. So this is also my preaching point. Like, we are working with cardiology. You should have a psychologist for any kid with a congenital heart defect. The psychologist should be seeing them at least annually. That should just be part of standard of care. Because as a parent, it's terribly humbling to say, maybe I need help. And you don't know what it is. It's like, I don't know. Like, is it me? Is it my kid? Is it bad enough? Like, all these questions where I'm like, maybe. But if I saw you twice a year and I knew you and I knew your child, and I saw your child in clinic and then I heard you describe what's happening at home, at some point I would be like, let's try this. And then I might not see you for 6 months, and then you would say, hey, that worked. Or you'd come back in 6 months and be like, worked a little, we need something else. And then if it was like after a couple of those visits, I'm like, you know what? You're still struggling. Let's see you more often. Let me see you monthly. Let me see you weekly. Let me, because I do think of the mental health piece as like making an ice sculpture. You're chipping away at it until you kind of get a shape that's beautiful. And so the first few chips, you might not see anything. But yes, so we need to be advocating at a national level that when kids are diagnosed with heterotaxy, and again, sometimes it's prenatal, right? It's so often prenatal. That's scary as a mom. And there are really good data that when moms are stressed, more cortisol crosses the placenta, and that affects mental health in the child. Like, we think about postnatal depression. There's actually really interesting work by Glover in the UK that prenatal anxiety and depression in the mom is as predictive or more predictive than postnatal depression for the baby at age 8. So we should be part of the diagnostic. So fight locally, because really mental health integration is where kind of the field is moving, but certain groups are more on it than others.
Well, I have a personal, our center, because of the age of our child, was like, no, we're not servicing children that old, because some of the literature that was being, that was coming out talking about the neurodevelopment of cardiac children was published after my son was born.
Right.
So we fell in a gap. And speaking to that gap, not only, so we had a really long trek. It took me 3 years of talk and being very concerned. These are my concerns. I want to see somebody. And getting in, it even took me the last year of it. I was like, look, I don't care what the reasons are. I want to see somebody. Get me into neurodevelopment. Get me into somebody. We talked to 3 different clinics within our system before someone would even consider taking him. And then we had the long wait. We waited 4 months to get into that provider, and then that provider saw us once and was like, you need a psychologist, and passed us on, which took another 3 months to get into. And believe, when we got in there, I mean, everything changed, and it was magical. But I can only, if I had been taken seriously 3 years prior, I think we could have avoided a lot of things. So what do you recommend for, we're going to have a long wait, even if we identify it early?
Yes.
And so I had 2 years of pushback before I got a year of a different level of pushback. What do you recommend there for our families?
Keep doing what you did. I mean, it's terrible, right? You know that thing where I say you have to be the teacher and you have to be the advocate? I wish the professionals were leading the charge, and we're not. And our clinic wait list is 4 to 6 months. And, a lot of people give up in that time. So, we really need to work toward more integrated care. So again, like in the feeding and swallowing clinic, I see those kids every time they come in. In Prader-Willi, I see them every time they come in. In EOE, I see them every time they come in. Well, heterotaxy is much more complicated than EOE. Not that that's not its own thing, but we really need to be working nationally as advocates to have, and again, cardiology tends to wait. It's their bread and butter. They don't recognize really, I think, how traumatic and scary it can be, right? Unless there's a transplant, and then they tend to get behavioral health involved.
All right. Well, thank you.
Yeah.
I do just want to give you guys some hope, because Dr. Bennett-Murphy has been working with Hallie for the last almost a little over 3 years. And she has personally kept Hallie from woodchucking her doctors or taking scissors into surgeries or many other things. For those of you that know Hallie Sass, I've seen a change in my child, and I had to fight that battle. I had to fight those doctors. I had to fight to be heard. And let me tell you, when you find that right doctor, when you find that right person that listens to you and starts to help, it's life-changing for these kids. So please make sure that you are not giving up, that you are continuing to recognize that mental health is a huge aspect of our heterotaxy journey for the whole family, and keep looking for that help until you get what you need. So thank you, Dr. Bennett-Murphy.
Thank you.